All right, Angie, thank you so much. And thank you everyone for joining us here in early January. Today, we're going to talk about saliva, serum, and urine hormone testing and compare them. We'll talk about the pros and cons, the appropriate time to test in each of those mediums. So we all know that hormonal systems are very complex and symptoms can be due to a wide range of imbalances. It's our job as practitioners to really determine the etiology, which is actually sometimes quite difficult. So I think what I'd like to say to start all of us out here today is that it's very important to listen to our patients' stories and to what they're experiencing. We need them to feel heard and honored. They have a lot of fear and frustration about what's going on. So taking that subjective account and matching it to appropriate objective testing is, I think, where medicine becomes very powerful. It is somewhat of an art, and I think it's important to remember both sides of that. So never looking at black and white numbers on a test report and having that pull you in an inappropriate direction. And also remembering to not just take the subjective experience, but also to match it to those objective test markers. And by the end of today, I just really want to arm you with that understanding of all of the different hormone testing mediums so that you can choose the type of testing that best fits your assessment goals, and you're not going to be led in an inappropriate direction where you are giving a treatment plan that just isn't right for that patient. So to introduce today, I want to start out with this chart. It's showing you, endogenous steroid hormone production. Where can you test? What medium, what bodily fluid can you test? And then also any type of hormonal replacement. Why, which one is appropriate and which one is not. So don't get too caught up. I just want to introduce it now. We're going to break it down. We'll start with one of these mediums and then add on to the end, so that by the end of this, you're going to feel really confident about which type to use and when. And as a reminder here, the steroid hormone cascade. The steroid hormones are made from a cholesterol backbone. So like cholesterol, the steroid hormones are not soluble in water. They are hydrophobic and lipophilic. So if you don't know any other chemistry other than that, this will serve you very well. You're going to do just fine. But it's a really important concept because urine and serum are water-based. Saliva is more favorable to lipids. So this right away is going to delineate and help you understand when to choose what type of medium. But because these steroid hormones are hydrophobic, when they are in these watery environments, they have to be bound to a protein carrier, or they have to be what's called conjugated, meaning bound to a substance that's going to make it water soluble. So again, I'm not going to talk about a lot of chemistry today, but just knowing this part is going to serve you very well. Now, if you've ever wondered how Lance Armstrong won the Tour de France 7 times and never tested positive for performance-enhancing drugs, today's lecture will describe that for you and tell you how that happened. So by the end of this lecture, I know that you are all going to be practitioners that would have caught Lance Armstrong and not allowed Lance to get away with this 7 times. This is a slide with a lot of text on it, so I'm going to distill this down for you, but I just want to give you this timeline to show you the testing evolution. It was in the 1940s and 50s that urine hormone testing actually first came out. They were using, at this point, a chemical method, a fractionated method via a solvent to make that soluble for testing. And so it wasn't very sensitive or specific. The 1960s, we started coming out with what's called gas chromatography mass spectrometry. That was more sensitive, so we're getting better and better. 1966 was that GCMS, and that was the first urinary steroid profile at that time. 1970, we came out with radioimmune assay, and that was for estradiol, and then we added testosterone and progesterone. It was the early 2000s that the LCMS, liquid chromatography mass spectrometry, finally came on. There was a lot of laboratories and specialty institutions using this, so it wasn't really used clinically at this point, but that is where it first started. And then it wasn't until the 1970s that we started using serum hormone testing as the mainstay. There were some specialty labs using LCMS at this time within serum testing, but it was very rarely used by clinical practitioners, probably if at all. Saliva testing first came about in the 1980s, but really picked up in the 2000s. And we saw Johns Hopkins University and also the University of California in 2010 and 2016 coming out with their own salivary institutes for bioscience research. And then the urine metabolites in the early 2000s, this is where we started using direct LCMS, which is really what you want to be looking for if you're looking at research. This is where urine metabolites become basically valid because it's so sensitive and specific. So just a fun little look through history there to see how we've gotten to this point. But bottom line, this is the juice. It's serum versus saliva versus urine. And the comparison of testing mediums has somehow gotten, I think, a little controversial in the field of medicine. But in my opinion, it's kind of like arguing over apples and oranges and pears. Is one better than the other? No, they're all legitimate, amazing fruits. I love them all, but I do choose them for different reasons. And again, the main takeaway I want you to understand today, there is no wrong way to test hormones, but there are pros and cons of each. So as long as you are aware of the strengths and the weaknesses of the testing medium that you're choosing, you can kind of work around any limitations that might be there from the get-go. So let's first start with serum. There are many advantages here. This is the best place to test for polar molecules, protein-based hormones, things like thyroid hormone, prolactin, LH, FSH. But those steroid hormones like estradiol are quite non-polar. They're hydrophobic. Because the polar molecules are water soluble, they are best tested in serum, but that non-polar becomes somewhat of a problem when we're trying to look in this watery substance. It is a well-accepted mainstream marker. It's basically the gold standard for a lot of different types of testing. And it's the most widely used medium in research settings. So that, I think, gives it a huge advantage when you're looking at that and you're trying to compare just side-by-side numbers. Quite convenient. You can get a lot of things drawn all at one place, and it's giving you a snapshot of total levels at the time of the draw. Some disadvantages here, obviously, a lot of people don't love needles. You are limited to venous blood through that venipuncture access, and it's convenient, but you could also argue it's a little inconvenient to get to the lab, get to the draw site, wait, maybe there's fasting involved. All blood tests, because they're giving that single point in time measurement, it's not reflective of this pulsatile nature that we see in human physiology. Anytime I hear that pulsatile nature, I always think about hot flashes. They come every few minutes, sometimes even every 30 seconds for some poor women, but that is just showing you that pulsatile nature of human physiology and estradiol in that case specifically. The tests for serum are measuring the total amount of hormone present, so it's not as reliable a reflection of the hormone that's actually available and active at the tissue site, the bioavailable hormone. So this is probably its main limitation. Those free levels to calculate in serum are very expensive and technically difficult. They're often not offered by a lot of laboratories. Instead, sometimes calculations are given for free hormone levels. And then we have this issue of binding proteins in the serum. That can actually obscure hormone levels, especially, say, if a woman's on oral estrogen, that's going to increase sex hormone binding globulin, and that's going to bind up more hormone, cortisol, testosterone especially, and estrogen. And so that's going to make the hormones look maybe lower. They're going to be more bound up, harder to be able to get a good reading on. Okay, it's not the most effective way to monitor topical hormone replacement, especially with progesterone. And I'm going to speak more on that as we move on. There's some nuances there that I really want to make sure I describe for you all. So here's that look at the pulsatile nature, which we see, especially with these steroid hormones. Every 10 minutes, you're seeing some peaks and troughs. So the problem with serum testing is we're not catching those. We may be just looking at a single point in time. We may be really looking at the peak or the trough and missing some of the average that happens there. And then again, one of the biggest challenges with steroid hormones in serum, they're largely bound to protein carriers. Hormones have that cholesterol backbone, so they're hydrophobic. They do not float easily in aqueous substances, so they have to be bound to proteins like sex hormone binding globulin, cortisol binding globulin, or albumin. There are methods to separate these hormones from their carrier proteins, but they are expensive and cumbersome, which is why they're usually not offered outside of research settings. Okay, so where this brings us is that when we're looking in the serum, we're looking at estradiol and testosterone as a total hormone amount that oftentimes can lead to misleading results. So the hormone levels appear to be normal or even high normal because of abundance of bound hormone or vice versa. Now, free testosterone is difficult and expensive to measure, just like other free levels. So many laboratories don't offer the service, but they do give you a free androgen index, which is intended to give a guide to the free testosterone level, but it's not a direct measurement. So this is an example of the calculation for free testosterone. It's called the free androgen index. It's the total testosterone divided by sex hormone binding globulin multiplied by a factor. So you can actually do this calculation yourself as long as you have the sex hormone binding globulin and the total testosterone. And some particular disadvantages to testing, this slide should say cortisol in the serum. So specifically, we're talking about cortisol here. So again, those binding proteins can obscure the free levels, especially if someone's using an oral estrogen. It's going to increase the binding globulin. It's going to bind in addition to testosterone and even estrogen. So a diurnal test, if you wanted to do that, you would have to have the patient visit the lab 4 times over the course of the day. Serum would be a great way to find outright levels that are very high or very low. So you would catch Addison's, you would catch Cushing's likely, but it's typically not sensitive enough to catch those functional changes which the majority of our patients are suffering from. Some patients have white coat hypertension or they are a difficult blood draw. You can see where that could increase stress and cortisol would be secreted in response. So this is a study showing just that venipuncture can cause a rapid rise in serum ACTH. So this study looked at ACTH level after venipuncture, showed that the level increased within 90 seconds following the blood draw, and then the cortisol level increased within 4 minutes in response to that. So you can imagine if you have someone sitting there potentially with the phlebotomist having a hard time getting to their vein, that could easily result in that amount of time and obscure the level that's more of an average everyday level for that patient. So again, with this table, we're going to start with the serum portion here that we've just reviewed, and we'll build on this from here so we get that big graph that I showed you in the beginning. So can you measure endogenous steroid production with serum? So the natural production of steroid hormones in the serum. Yes, you can, and you can use that as a baseline, meaning from there on out, every time you go back to test that again, you can compare it to the first value, right? That's a fair way to do that. Can you understand oral supplementation with serum? Yes, with the caveat, and I would say this is a large caveat, that the oral delivery, because of first pass metabolism through the liver, is going to create a large amount of conjugated metabolites pretty quickly, depending on the timing of the test compared to the timing of when the person took that supplement. You may not be seeing a whole lot left of the actual parent hormone in the serum, right? Because most of that's going through the liver. It's going to be broken down pretty quickly and moved out. It is not the most effective way to understand topical hormone delivery. Again, I'm going to dive into all of this and show you the physiology about what's happening there and why I'm saying that. Vaginal delivery, very much the same as transdermal or any other topical delivery. So you're not going to see that reflected well in serum either. Sublingual, I'm giving this a maybe because The majority of sublingual delivery should be delivered transdermally, right? Moving underneath the tongue through those small capillary beds to the tissues. So very much like another transdermal or even vaginal delivery, you will be able to, you won't be able to see that in serum well. However, a lot of patients are swallowing some of that orally. That's just kind of the nature of it. Some do it more so than others. So you will get some absorption in an oral delivery. So then we go back to, can you track oral delivery in serum? Yes. But again, with the caveat that it's going to be metabolized quite quickly. And so you're not going to have a whole lot of that parent hormone left. Serum is an appropriate way to understand pellet therapy or intramuscular therapy, and that's because these delivery mechanisms and movement through the body are very similar to natural endogenous organ production. They do pass through portal circulation, unlike the transdermals, so this would result in more of a steady state, and you could get a sense of therapeutic level there. So let's move on now to urine. No needles needed. It's a very stable medium, and it is the only way to see how the body is metabolizing hormones. How is it being broken down? So whether that's endogenous production or by supplementation. Remember when we talked about that serum testing being reflective of a single point in time? Well, with urine, the natural pooling in the bladder before a void results in the ability for urinary testing to provide an average of the hormone and metabolite secretion. So this process naturally smooths out that pulsatile nature of hormone secretion. It's almost creating like a pooled tube right there in the bladder. So providing an average of hormone secretion in a 24-hour period. And this is true when a lab asks for multiple collections or even a 24-hour collection. That would obviously be the best way to smooth out that pulsatile nature. But with the 4 different multiple samples, usually a small aliquot is taken from each sample and it's pooled into a pooled separate tube, and that is then used to ascertain the hormone metabolite levels. So we have 3 types of urine testing. We have liquid urine testing that is composed of a 24-hour collection or a multiple point collection or an AM collection, and then dried urine testing, which is a 4-point test. There are some advantages to dried urine. It does have analytical sensitivity. It can detect compounds in very small concentrations. And when we're talking about urine metabolites or hormone metabolites that make it into the urine, that's what we're talking about. We're talking about teeny tiny small particles here. The components that are present in very low concentrations can be undetectable in dilute liquid urine. So that measure, if you reconstitute the urine with a reduced volume of liquid. Now, I will say the analytical enhancements using LC-MS have basically taken this problem out of the picture. You very, very rarely find a liquid urine sample that is too dilute to be able to test. But before we had LC-MS and these more analytical enhancements, this was a part of the draw to dried urine. The stability of these dried samples is also enhanced. Bacteria and other cellular components in the urine do not continue to metabolize or produce any compounds of interest that might skewer the testing. So that is another benefit. And the drawbacks are that the patient does have to restrict their water quite a bit prior to collection at less than 20 ounces. The filter paper cards that are used are actually designed for whole blood, so extracting other bodily fluids is a bit inconsistent, maybe error prone, especially in the dilute samples where the variability is a little bit higher. Since the serum components, or urine, are reported in terms of excretion per creatinine, this creatinine level is very important because you're using it to calculate everything from there on out. With the dried sample, it's actually estimated based on the standard extraction of the dried sample back into a liquid form. So that variability associated with the creatinine determination leads to a higher degree of imprecision and a lack of reproducibility when you compare it to a liquid urine sample. The patients need to drop their samples onto a card and dry their samples in an undisturbed area for 24 hours prior to shipping. That's going to naturally just increase the risk of exposure or contamination. Who knows what patients are doing in their bathroom with aerosol, hairspray? I don't know what, you can just see how that could lead to some potential problems. Now, benefits to liquid urine testing. We have ease of collection and method standardization. This has been a common medium with other test markers for a long time. And the determination of creatinine is direct. It's accurate. This is important because, again, it's used for the calculation and controls for variability in that urine concentration. So we do also have less sample handling here, so there's a decreased opportunity for errors. It's very sensitive. There used to be issues with dilute samples, but again, with these analytical enhancements using mass spec, we really have this increased magnitude of analysis down to picogram levels, parts per trillion. So it's more than adequately sensitive to measure these components of interest, even in very dilute urine samples. With liquid, you don't have to restrict water intake, but someone who drinks maybe liters and liters and liters of water possibly could have a urine sample that is too dilute. In all the years I've seen this testing, I have yet to run across this, but it is possible. These samples would be rejected by the lab. And again, it's rare, but it could happen. The liquid urine does require stabilization steps. So there's not continuous, components of interest that are going to impair that reading. The patients are generally asked to freeze the samples before sending back. That in and of itself is adequate. However, a lot of times the collection vials often contain a preservative just as an added security measure to make sure that sample is stable. So hormone urine levels are not a direct measure of the bioavailable hormones. And that's important to remember. It is the best place to measure hormone metabolites, but the parent hormone, the unconjugated hormone, not so great. When the bioavailable hormone molecules travel to the liver, they are conjugated to a glucuronate or a sulfate, which makes them polar, allowing them to be water soluble to float freely in the urine. So these conjugated forms of the hormones are found readily in the urine, but it's not an ideal medium for measuring the free hormones so that you're getting an understanding of, hey, how much hormone is getting to my patient's brain, to their bones, to their cardiovascular system. Additionally, it's difficult to measure the therapeutic levels of hormone supplementation, no matter the route of administration. And urine does not reflect that tissue uptake. It would be like measuring how much food someone's eating by going through their trash can, right? There's a lot of assumptions that you have to make to get to that decision of this is how much hormone is getting to my patient's body. And then you'll also see high metabolite levels with oral medications because of that first pass liver metabolism. And depending on the timing of that test, certainly, but that oftentimes is the case where it's going to look like those levels are just sky high. And you may think if you're trying to use that to adjust dosages, you're probably going to be conservative and back up on the dosing, and it may not be necessary. So urine can be used for measuring diurnal cortisol levels, but the free cortisol output reflects an average of the time since the previous urine void, usually in hours. You're comparing that to a saliva sample where you're getting an almost instantaneous assessment of the cortisol level at the time of the time where the sample was taken. So just think through that too, that is going to be a difference when you're comparing them together. Now let's talk about metabolism and detoxification here. That'll give you a little bit more information as to what we're looking at when we're looking in the urine metabolites. So phase 1 enzymes are responsible for breaking down fat-soluble toxins. So it's basically taking phase 1 cytochrome P450 enzymes. They're going to biotransform these harmful substances, so toxins, but also steroid hormones, all going through this same process. They're adding a hydroxyl carboxyl amino group via oxidation, reduction, or hydrolysis. So that's what's happening just in general in phase 1. So let's see how this relates to estrogen. Estrogen is metabolized via phase 1 and phase 2. but primarily in the liver. And this phase 1 detox, the estrogen is hydroxylated via the CYP system. So of these hydroxylated phase 1 metabolites, which are often called the catechol estrogens, I've highlighted those in red. The 2-hydroxy is thought to be safe, less estrogenic, whereas 16 and 4 are thought to be less safe, more estrogenic due to their potential to cause DNA damage. So these are the reasons you might be using urine testing, because you're interested in getting these numbers. What's happening? Is my patient going more towards 2-hydroxy? Do they have a ton of 4-hydroxy? And then also, are they moving into phase 2? And you can compare all these levels of the metabolites. So you can get a lot of information there. So you likely heard of diindole methane as a treatment for optimizing estrogen metabolism. This lecture isn't a lot about treatment, but I do want to show you it's because of studies like this that's showing that diindole methane can increase the 2-hydroxylation of those estrogen urinary metabolites. So moving it away from 16 and 4 towards the 2. And this is part of the reason you would use the testing, is because then you can say, hey, if my patient's going a lot towards that 4-hydroxy, I don't like that because that's estrogenic. I can use something like diindole methane to change that direction. And this is just a quick study to illustrate here. There's also evidence for using estrogen metabolite testing in males. This was looking at cases showing 2-hydroxylation over 16-hydroxylation may reduce the risk of clinically evident prostate cancer. Okay, so more 2, less 16 reduces risk. Now let's talk about phase 2. This is where the enzymes break down substances into water-soluble components so that they can safely get out of the body. And that's accomplished by adding various groups like sulfur, glutathione, glucuronic acid, amino acids, methyl or acetyl groups, all of those options. There are ways to help the body to move through this process. And there are nutrients and things like that where you can give the transferase enzymes, including COMT, more juice, basically to be able to, move phase 1 into phase 2. Okay, and this part of detoxification is actually important for the majority of medication detox. So it becomes very, very important. You can look at this on urinary testing. So in phase 2, the metabolites are either oxidized via CYP, not what we want, or they're methylated via COMT enzyme. So these methoxy metabolites, which I've highlighted here, they're produced via methylation. They typically don't cause DNA change or tumor growth. So again, this is a very important part of why you might want to be looking at these numbers, because you can see how much is getting towards that phase 2, how much methoxy metabolites does my patient have. Hopefully they have a lot. And if they don't, there are things that you can do to come in and change that. The low levels of methylated or methoxy estrogens relative to their precursors would tell you that this phase 2 isn't working very well. We need to support that COMT enzyme that's that's making that transition. So if detoxification doesn't happen from phase 1 to phase 2, it instead gets oxidized via CYP peroxidase, and it leads to what are called the quinone metabolites, which have the potential to initiate DNA changes and tumor growth. Okay, so again, a reason why you would be using this. All of the hormones have metabolites, and all of those can be monitored in urine testing. I would say the estrogens are probably the most well studied to date, but the research is ever developing in this age. So I would, advise you probably keeping a good eye on those estrogen metabolites is going to be really important. We have another Wellness Wednesday webinar later this year that's going to focus on urinary metabolite testing and treatment specifically and go into a lot more detail. So I know a lot of you probably are interested in that, so make sure you catch that one. But we'll stick to the plan for today and just focus on, comparing the testing mediums. So a very brief summary of why you might want to monitor these urinary metabolites. So again, as far as the estrogen metabolism, you may be able to gather information about carcinogenic potential, which I just showed you, gather information about methylation and how well is that COMT enzyme working. You can look for evidence of phase 1 and phase 2 detox. And then as far as androgens, you can go deep into a deeper evaluation of carcinogenic potential, certainly things like PCOS or metabolic syndrome. It's going to give you an understanding of enzyme activity within the androgens. So aromatase and 5-alpha reductase are usually the big ones that we're interested in. And then you can also look at cortisol metabolites that can give you information about thyroid issues, inflammation, metabolic syndrome, even obesity, and how that shifts and how that changes. You can look at the information of cortisol versus cortisone. And then as far as progesterone, a very, very small amount of progesterone, the actual parent hormone, makes it into the urine. And a lot of that has to do with that very strong non-polar nature of that molecule. Remember when I showed you that steroid hormone cascade? So not a lot of it even makes it into the urine, but you can look at the progesterone metabolites to get a little bit more information about that. But far and away, information on metabolites like these is where the urine hormone testing shines. No other medium outside of research settings. You can look in serum for metabolites, but in clinical practice, there's no other medium that you can use in that way. Okay, so not to kind of, keep harping on this, but I think this part is confusing. Please remember that when you're using urinary testing, the level of the urinary parent hormone, meaning that unconjugated original hormone, so estradiol, progesterone, that is able to be picked up in the urine is very likely not representative of what's circulating or active at the tissue sites. The urinary metabolite levels that you're testing may also not be representative of circulating or active hormone levels. It's going to usually overestimate the level of oral supplementation because of that first pass conjugation. And it's definitely going to underestimate topically applied hormones. Those hormones are not forming significant metabolites because of the way they're absorbed and the biomechanics, the way they're moving through the body. And I will discuss more on that in just a moment. But this is the perfect test to understand how the hormones are breaking down and the pattern and the direction that they're moving out of the body. So here's our table again. We've already talked about the serum portion, so let's add on urine. Can you use urine to assess endogenous hormone metabolites? Yes, definitely. You can use that as a baseline as well. Can you use it to assess oral? Yes, with the caveat that, again, the metabolites are going to look very high, so don't let that alarm you. You cannot use this to track topical therapeutic dosages, nor vaginal, nor sublingual, unless the sublingual, the vast majority is being delivered orally. So they're swallowing most of it rather than letting it go into the mucosa or under the tongue. Then you have that caveat that, yes, you can see that in urine, but a lot of metabolites are going to be showing. You can use it for pellet and intramuscular injections, just like I said before with the serum, because it's produced and moves a lot like end organ or organ production. Okay, so again, the take home, it's the perfect test, urine, that is, to understand how hormones are moving out of the body and how various metabolites are being formed, potentially affecting physiology and risk factors. It's just not the best test to monitor dosages of BHRT or HRT. So this is an example of the doctor's data 4-point liquid urinary hormone metabolite profile. This is called HUMAP. And we spent years in R&D researching the best and the most accurate way to test these samples. We came to the determination that liquid was giving us the most reliable and reproducible numbers. So that's what we're using here. And it is using LC-MS. So it's very sensitive, very specific. We're able to get things down. We can even report progesterone, the parent hormone, in the urine. You won't see a lot of it, but it is there and we can definitely report it. So it's giving you an overview. This is just the first page here. I just wanted to let you see it just so you know what this looks like. But we'll have a whole presentation diving into this and looking at treatments and different patterns that show up. So let's move on to our last medium today. We're going to discuss saliva testing. This is where you can see the bioavailable or the unbound portion of the steroid sex hormones. Remember, this is a very different hormone than thyroid hormone, some of those polar hormones. very much like cortisol. It's a steroid hormone. Cortisol very readily tested in serum, as are the sex hormones. So let's think about steroid hormone physiology. These endogenous hormones are secreted from the ovaries, the testes, or the adrenals, and they're wrapped in protein envelopes. So sex hormone binding globulin, cortisol binding globulin, et cetera, so that they can be transported in the serum. These protein-bound hormones are not biologically active. A lot of times what you are more interested in as a clinician, I would guess, is that 1 to 10% of hormones that's unbound, that are biologically active, that are actually getting to the cellular components of your patient's body and having an action. So saliva is the only way that you're really going to be able to directly understand that. You can use this medium to track the therapeutic administration of all different hormone types. The timing, we call this a dosage interval, does need to be followed correctly, but you can do that. Patients can collect at home. There's no needles involved. And more advantages here, definitely easy to collect and capture multiple samples. So we can catch and time for a luteal surge, where the progesterone level should be at its highest. We use a pooled tube to measure so we can avoid these peaks and troughs and be able to account for that pulsatile nature of hormones. There's no special processing needed prior to shipment, and it is really the only effective and accurate way to measure topical, vaginal, rectal, sublingual, any type of hormone therapy. Most specifically, it's the only accurate way for transdermals. And I think that's most important because a lot of times we're choosing that because it's avoiding first pass metabolism. So serum testing is reflective of that single point in time, not representing the pulsatile nature. Saliva testing, we're usually taking 4 collections to get a better idea of how to treat, and we're getting a pooled sample so we have a nice steady state. Also, urine testing will be a nice way to avoid or being able to capture that pulsatile nature. And because saliva can be collected anywhere, it's possible to measure things like the cortisol awakening response, which would require the patient to collect on waking at the normal 30 minutes post-waking, where cortisol should be at its highest, and also at 60 minutes post-waking. So you can get a very specific look at that and look at that cortisol awakening response. Not really possible to do that in a clinical setting or with blood draws, okay? Restricted to steroid hormones. So you cannot use this medium for testing protein-based polar molecules. So thyroid stimulating hormone, FSH, right? So it limits to a number of specific assays. It's the steroid hormone. It's the cholesterol backbone hormones. It is technically challenging. It needs about 10 to 20 times the sensitivity. And this is where you'll see sometimes labs using a direct assay versus an indirect or extraction method. You'll know that the lab is using a direct assay when it requires less saliva. So look for the size of the tubes and you'll be able to see that. The saliva specimen, as a disadvantage, can come into contact with a topical or a sublingual hormone. So if the patient has it on their lips or their hands, that can contaminate the sample and can make the levels look far higher than they actually are inside the body. It's just because that small molecule actually came into contact and is literally in the tube of saliva. So that is probably one of the trickier parts. You just have to educate your patients and make sure they're being clean about what they're doing and that they understand the potential for that to happen. So despite these limitations, saliva is a great medium for hormone testing, especially monitoring hormone therapy and choosing which dose is correct for that patient. And the main reason is that concept of free hormone versus bound hormone. So when the endogenous hormones are secreted from the ovaries, the testes, or the adrenals, again, they're wrapped in protein envelopes, sex hormone binding globulin, cortisol binding globulin, et cetera, so that they can get around in the aqueous serum or even in the urine. So with conjugation, that's mostly an aqueous substance, right? So it's like mixing oil and water. That's the problem. So these when it's bound to the protein carrier, it's not biologically active. And again, probably as clinicians, I speak for myself, I'm more interested in that 1 to 10% that's unbound. Why is my patient having hot flashes and night sweats? Why are they having all of these hormonal symptoms? So saliva allows us to look at that bioavailable hormone level, both the endogenous production and the therapeutic dosage level. Saliva is representative of the capillary flow around the saliva glands. Saliva actually starts out as blood, moves through the capillary glands. These are non-polar molecules. The hormones, they freely diffuse across the capillary membrane and into the salivary tissues. So this allows us to take a look at that bioavailable fraction of the hormones. And it's assumed that the saliva is representative of what the hormones are doing and moving around the capillary beds in other tissues in the body. Now, these endogenous hormones are attached to protein carriers, but when the hormones are applied transdermally, they're not moving around as readily with those sex hormone binding globulin protein carriers. They're often attached to red blood cell membranes as a different way to move through there. But either way, they're moving through these capillaries. They're typically cleaved off. They're able to move into the tissues directly. So you actually don't see a whole lot of that in venous circulation. So when progesterone specifically is absorbed through the skin via a transdermal application, it's not coated with that protein carrier. It's carried by the blood's fatty components, the red blood cell membranes. So that transdermal progesterone absorption is quick, it's efficient, it shows up in saliva within minutes to hours, indicating that it's very well absorbed and available to the cells in a biologically active form. Now, all steroid hormones are non-polar. However, the further you get down the biochemical steroid pathway from cholesterol, the more polar the hormones become. They're still non-polar, but they're less non-polar, more polar. Therefore, estrogen, much more polar than progesterone, which means that the red blood cell membrane isn't as attached or attracted to estrogen as it is to progesterone. Progesterone, it's like, I'm holding on to this one. It's very fat-like. I need to really hold on to this, okay? So if any of you have experienced seeing a serum level rise after applying transdermal hormones, it's likely because the dosing was supraphysiologic, meaning it maxed out the tissue site, and then it basically, there was so much left over, it almost like slopped over into the serum, is how I explain that. So when the absorbed progesterone exceeds the carrying capacity of the fatty material in the blood, only then will you see it in the serum. It slops over and you'll see it in those levels start to rise. So this is true of estrogen, testosterone, progesterone, but it's true of progesterone to a greater degree, if that makes sense, because of that non-polarity. And this plays out in the literature. We see that transdermal hormones are reflected in saliva, but not in other mediums. So the fact that the transdermal hormone supplementation is not found readily in the serum has been somewhat controversial. What practitioners and researchers have often concluded is that the hormone is just not going into the body at these lower dosages. And that's led to patients the dose being increased as practitioners and researchers are attempting to watch for a rise in the serum to let them know, okay, now it's in the body. The problem is we've overdosed all the tissue site, and now we just have such an exorbitant amount of hormone in the body. So we now know through various testing of tissues that the hormones are being absorbed. It's just not showing up in the venous blood. And that's most relevant for progesterone, but for all the hormones. So this was a study using 64 milligrams of topical progesterone. You see a saliva change remarkable within 30 minutes, but you don't see any statistical change in the serum or the urine level. Here you can see there's very little rise in the serum. This is this bottom graph here after the application of progesterone of 20 milligrams, but you do see a rise in saliva, quite significant. If you were testing in serum, the provider would assume that 20 milligrams of progesterone is not sufficient. It's not doing anything. It's not protecting the endometrium. It's not protecting the breast tissue, all of that. However, we can see the salivary levels of progesterone do reflect therapeutic levels. And this is why we have what's called these dosage interval recommendations, and that's to apply hormones 12 to 24 hours before saliva collection. Because when we do an application, you can see, right away, we get a large bolus dose right there. But after 22 days, we get more of a steady state, a new therapeutic baseline that's reached. So this is where you want to be careful. Testing your patients, they need to be on the hormone replacement topically for at least 22 days before you retest them, right? So that you're capturing this new baseline. And then also not just right after application, which is where that 12 to 24-hour window comes in. We want to see what is the average of their tissue level on just, a normal day for them. So your patient is applying hormones to the skin. How the heck is that hormone reaching the target tissues? One theory we've already alluded to is this red blood cell, basically a hormone taxi. So the red blood cell membrane is where the hormone is kind of like hitching a little ride on and going directly to the tissue, being cleaved off. This is a study done at the Red Cross, which is a primary collector and storer of blood donations in the US. They were looking at red blood cell membrane uptake of progesterone, corticosteroid, and cortisol in fresh and 42-day stored blood. All of the hormones had an affinity for the red blood cells. Progesterone showed a much greater affinity. So that makes sense to you now, right? Because it's more non-polar. It's like, oh, I need something to hold on to get around in this watery substance. So just indirectly, this data is just supporting that the red blood cell is a carrier medium for topically applied hormones in general, especially progesterone. This trial was looking at estrone, estradiol, estriol, progesterone, and testosterone, showing that as much as up to 35% of that total hormone content of whole blood is confined to the red blood cells. So they were just saying, hey, this is also a carrier medium, not just sex hormone binding globulin or albumin. And the red blood cells, are acting as these carriers for transdermal hormones, but those bonds are overall, they're fairly weak. The red blood cell moves through the capillaries, the hormone cleaves off that carrier red blood cell and moves into the cells. So they're all weak bonds. I say progesterone is a little bit stronger, but in comparison, they're all weak. But if you compare them to one another, progesterone is stronger. And then just a picture here. I think this is just such a good visual to take a peek at. And you can even show your patients this, when they're applying this transdermal hormone, all of these little teeny capillaries are pulling that hormone in. It's going to the tissue site. It's cleaved off with free diffusion going straight to the tissues. But you can just see how much of a sponge that skin and those capillaries are. So let's go back to that question. Why do we not want to use serum as the method for testing transdermal hormones? Well, there's several reasons why, but the first reason is the way the serum is routinely handled. So when blood is drawn from a patient who has applied transdermal hormone, we understand that a large portion of that is attached to the red blood cell membrane, right? But to separate serum, the blood is allowed to clot and then it's spun down and the red blood cells are discarded. Meaning red blood cells along with that transdermal hormone that's attached to the membrane. So that's all thrown out. And then we're looking for, where's the progesterone? Where did it go? It's not here. Another reason the transdermal hormones don't show up well in the serum is just basic steroid hormone physiology. These steroid hormones are lipid soluble, so they're freely diffusing through the cell membrane, and they're going to the cytoplasmic receptors. That receptor hormone complex then goes into the nucleus, attaches to the genome. The genome is then activated to produce messenger RNA. Then that goes to the cytoplasm, translated into enzymes, which alters metabolism. But that initial receptor hormone complex is then catabolized within the cell by those cellular organelles. So you're never going to see that again. You're never going to see that parent unconjugated hormone ever again. You may see end products or metabolites leaving the cell, but that original portion you just don't see. Another theory is that the lymphatic system serves as a delivery system for sex hormones also. The lymphatics track the vascular system throughout the body, and lymphatic fluid is highly non-polar. So thus it would be a very compatible medium for steroid hormones. My theory is that all of these things are happening at the same time, and this is just really why you're not really seeing the progesterone level or the hormone levels rise when you apply physiologic doses of transdermal hormones. You will see those levels rise if they're super physiologic, but we don't want to go there. So to summarize, transdermal hormones are free. They're largely not bound to protein carriers. They have weak bonds with red blood cells, so they're quickly transferred into the cells by free diffusion. The red blood cells are discarded when serum is tested, so anything that was there, we're not going to see it anyways. The hormones are catabolized within the cell by these cellular organelles. You're never going to see that unconjugated parent hormone again. And then the lymphatic system is carrying some of that portion of hormones too. So you are just not going to see those transdermals in the blood or the urine, and you're not going to be able to track correct dosages of transdermal hormone therapy. So this can lead us to our table here again. So saliva can be used to monitor any route of hormone replacement. It's the place you can also look for endogenous steroid production. It's the only place that you can reliably monitor transdermal or sublingual therapies. And these routes of administration are really popular because they're avoiding first pass, which is great. We have less damage to the liver, less irritation of the liver. One question I often get is that, is it true that you cannot test sublingual hormones in saliva? Not true, you certainly can, but it can be a little bit tricky. So think about this. You're using the same medium to absorb the hormone as you are to test it. So the potential for contamination becomes much higher there. So if you think about that, we're testing in picograms per milliliter. So there are 1 billion picograms in every 1 milligram of hormone replacement. So think about that. If one teeny tiny molecule of that hormone replacement actually ends up in the tube somehow, maybe it was in the oral cavity under the tongue, people that have orthodontic kind of things in their mouth, that can become a problem and you can get contamination, okay? So it is absolutely possible to do this and to see therapeutic levels, but you do have to have patients follow the directions where they have to like rinse out their mouth. They need to wait 24 to 36 hours, so a little bit longer than a topical application. And just being mindful that they're not, have hormone on their hands, touching everywhere, touching their face, having it in their mouth, and then just moving that into the tube. So as long as the directions are followed, I see that not to be a problem. However, you can see if that's not counseled to the patient, it can easily become a problem. The only time I've ever had a patient where we just could not get a good reading was somebody that had like a metal retainer that was fastened permanently in her mouth, at least semi-permanently for a time. And I think the hormone was just sticking around in some of those little spots. And so we didn't use it for that, but in every other case, as long as the patient is following the directions, it shouldn't be a problem. Okay, and here is just an example of what that saliva hormone report looks like with doctor's data. So you're looking at the cortisol level, the DHEA on the left, and on the right, you're looking at those steroid hormones, estradiol, progesterone, we're giving you a ratio, and then there's also testosterone and DHEA. So with saliva testing and urinary testing, it's imperative that your patients are following these correct dosage intervals. It's really common, and I think probably one of the main reasons I see levels that aren't going to be clinically helpful to you is that the patients were not following the directions or the dosage intervals appropriately. So when you have the question, is my patient on the right dose of hormone replacement? These dosage intervals are very, very key, and making sure they followed this is going to give you the information you need if you can rely on those results or not. Okay. And then also we have this testing schedule for cycling women. It's really important that we're trying to test at the right time of the menstrual cycle. The reference ranges are based on a luteal phase surge, especially for progesterone. So these were established in saliva. So if you're trying to catch that, again, in serum or urine, same rules would apply, but you want to catch that luteal surge testing on day 21 of a standard 28-day cycle, give or take a couple days. And then if the cycles are longer or shorter or regular, irregularly, regular, blah, 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 this chart is going to help you decide when to have your patients test. So let's put this all back together. All testing mediums can be used as baseline. If you're trying to track supplementation levels, it's really important to choose a hormone test medium that accurately reflects how much hormone is being taken up by the tissue. Probably you're not interested in how much is circulating in venous blood or being excreted in the urine. Serum and urine grossly underestimate tissue uptake of transdermal or transmucosal hormone, and that often leads to overdosing. It may be possible to monitor oral and pellets or intramuscular supplementation in serum or urine with caveats. The urine is the go-to way to understand metabolites, and I think this area of research is very interesting. It's ever developing, so it'll be exciting to see how things play out in the next decade or so. Tangential but important question, patients on oral contraceptive, is it worth testing hormones? So I would say 9 times out of 10, I'm not testing them if they're on an OCP. I know what the hormone levels are going to be. I know that that's suppressing ovulation. Oral estrogens are increasing sex hormone binding globulins. You're going to see a decrease in testosterones. For the most part, we know that this is kind of a cookie cutter way that the hormones are going to be shown. This is not reflective of what is my patient's state of hormone. This is reflective of what is the oral contraceptive doing to my patient's hormones. So there are rare times when I might use this, but for the most part, I think testing hormones with this is just not going to be clinically helpful for you. You already know what the levels are going to be. Here was an example of a saliva and serum testing side by side. This was in a 37-year-old female with a post-hysterectomy, tested ovaries removed as well, serum and saliva at the same time. She had recently taken oral DHEA and she was using a topical progesterone. So you can actually see that topical progesterone is reflected in her saliva results. That's what's here on the left. But the serum hasn't changed much. She's still in the postmenopausal range. Okay. She also has elevated DHEA. Maybe we can say, did she follow the correct dosage interval? Yes, she did. Okay, this dose is just too high for her. So what's happening here is this DHEA is elevated. It's pushing over into testosterone. So you'll see a little bit of testosterone here. Very likely this testosterone is the reason she has elevated estradiol, but you're not going to see any of that in the serum. Now, we also found out that she had a husband at home using topical testosterone. That's another reason you'll see elevations in somebody's testosterone if there's transference happening, if there's any of his testosterone getting onto her skin, and that it is very likely that she's getting maybe a little bit of that, but also some of it is converting from DHEA. Probably both of those things are happening. So I just wanted to show you that. And then why is her progesterone elevated? She was using, so she had a prolonged dosage interval, which is why we're showing not showing this supplementation range. She would have been normal if she had, used this within 12 to 24 hours, but she was greater than 72 hours. So we're like, why is this still high? 20 milligrams topical progesterone, that's not an exorbitant dose. That should be reasonable. We found out she was actually applying the progesterone to fatty abdominal tissue. You'll see sometimes over-the-counter products will recommend to women to apply it to those locations. And what happens is that fatty steroid hormone likes to hang out in the fatty abdominal tissue or fat tissue in the body. It feels more comfortable there than floating around in the water, in the aqueous serum or any other substance. And so that is going to cause kind of a pooling effect. And so you get inconsistent dosage levels when you're reading these progesterone reports. Oftentimes it looks higher or sometimes even lower than what you might expect. And it's because of that pooling that happens, and the progesterone is released at maybe inconsistent levels. So we had her move to a thin skin area. So the inner forearms, backs of the knees, tops of the feet. Okay. So just as a summary here, that DHEA dose was just too high for her. So it's showing an elevated estradiol, moving to DHEA, testosterone, and estradiol. Her partner's testosterone probably, showing is part of the reason why that's also elevated, but you're not seeing any of this in the serum, right? And that progesterone being high because she was applying to adipose tissue. So there's a side-by-side in my interpretation of what's going on there and why there's differences. So let's go back to our friend Lance Armstrong. Why was he able to, and how was he able to avoid detection for so long? You probably can guess this at this point, but Armstrong and his teammates had many ways to avoid detection. One of them was by administering testosterone sublingually, with the knowledge that this type of supplementation would not be reflective in serum or urine testing. And that was commonly the way that they were administering these tests to athletes. He's basically able to exploit the weaknesses in the anti-doping testing system. So studies have been done that now promote saliva testing as a better screen for doping because of the ability to use these transdermal formulas. So this was a study looking at transdermal testosterone showing increase in saliva levels and no increase in urine or serum. So they're just saying, hey, we better, start moving to this as a better screen for doping. Now, I hope this helps for you. I tend to think of my patients as a little garden, basically, and I'm trying to tend to that garden. So I want to assess, does my patient have enough starter material in their garden, enough nutrients to feed the plant material? That's what I think of the saliva report for. So I want to know how much nutrients is in their tissues. Okay, and then if we have that good balance of starter material, is that material being properly moved through the garden? In the end, is it moving in the correct direction? Do we have stagnation in any areas? Do we have root rot in other areas? Do we have total dryness or atrophic parts of the garden? And that's where I'm using that urinary testing to see in which direction is it flowing? What pattern? Is there a high risk here? Do I like this pattern? Do I want to move it? And then with hormone replacement, just making sure, I'm looking at that as well. So I hope that helps, just big picture, to kind of understand the differences there. So as the end today, we've had an evolution of hormone testing over the years, but I do want to leave you with the uplifting idea that at least we're not living in this time any longer, right? This is a news article dating back to the same time from Premarin use was at its peak. So I just encourage you, just because we've always done something, a certain way, doesn't mean we have to continue on. This is kind of the new frontier in medicine. We have to question the status quo. It's good to know the pros and cons of each medium so that you can make the best choice for your patient in front of you. And again, there's no wrong way to do this. Just make sure you're working around those strengths and weaknesses of each medium. So whichever medium you use, it's going to be fine, but just as long as you know that, go back to the science to really critically understand, when those types of mediums are to be used, and always make sure that you're matching that subjective patient experience with the objective testing. And that's where you just have really a lot of power in medicine, and you can do really wonderful things for your patients. So thank you so much. I'm going to leave it over for questions and hope that I can answer all of those for you.